Chapter 8 is Medicare, Physician, and Other Health Professional Payment Systems. So in this chapter, we are going to be talking about a couple of other professional payment systems that we have. You can see here our learning objectives. We've got our RVSs. We're going to learn about our Medicare, Physician, and Other Health Professional Payment Systems, our quality payment programs. So reimbursement for physicians and other health professionals occurs under our Medicare Part B. This is some of the services. We have office visits, diagnostic procedures, surgical procedures, therapies. They can occur in various settings, such as the physician's office, ambulatory surgery centers, hospital inpatient, outpatient, skilled nursing facilities, as well as outpatient dialysis centers and hospice. They can be provided by physicians, chiropractors, nutritionists, physician's assistants, nurse midwives, nurse practitioners, podiatrists, audiologists, physical therapists, occupational therapists, speech language pathologists, can be social workers, variety of different care providers. The majority of that care is going to be from a physician. So there's two parts that we're going to talk about of the payment system. The first is the RVS. That is our resource-based relative value scale. This is a resource measurement system that assigns values to services, and it's based on the cost of furnishing those services in different settings, the skill, the training that is required to perform that, and the time and risk that is involved. So the relative value, or RVU, is the unit of measure. And this is just like what we talked about in Chapter 5 with the inpatient and Chapter 7 with our outpatient. Each service gets that RVU, and then it uses a conversion factor to come up with a payment. And it allows for comparison of labor, skills, supplies, cost, and all of that. The next one, number 2 there, is our Medicare Physician Fee Schedule. Sometimes that is abbreviated as MPFS. This provides the maximum amount of money that Medicare will pay for a service. It can be increased by increasing the volume of the services. So the fees are predetermined, but it's not prospective because we don't know how many services will be provided. It is determined by multiplying the RVU by the conversion factor. So these two terms sometimes are kind of used interchangeably if you see those two terms together. Remember that one is the measurement and then one is how we're going to get paid. So these are the pieces that we look at when we're looking at our payment system. We have the RVU, that is our relative value. It is assigned to HCPCS codes, and that measures our resource utilization. Now, just a reminder, our HCPCS codes do include our CPT, as well as those HCPCS, which are a lot of times DME, anything that doesn't fall in CPT. We have 3 RVU categories, and we're going to talk about those, but each one has a unique weight. Next, we have the GPCI, which is the Geographic Practice Cost Index, and that's where we make an adjustment because of the differing cost. Remember that, as we've talked about throughout this course, cost varies based on the location or what area of the country that you're located in. So each RVU has a corresponding GPCI. And then our conversion factor, that's what sets that fee schedule to be more than what Medicare is going to pay. It is the national dollar multiplier that sets the amount of payment. So do you know those three pieces: RVU, GPCI, and CF? Now, remember that the RVU has three categories. These are the three categories. We look at work, PE, and then we look at the MP. Work is the time required and the intensity of the procedure. This kind of covers the physician's salary. It looks at four areas: the mental effort and judgment, technical skill, physical effort, and the psychological stress. This takes up 51%. Do you know those parts: mental effort, judgment, technical skill, physical effort, and the psychological stress? The second part is the PE. This is our overhead cost. This is our operational cost. And the PE stands for practice expenses. So this would be clinical and administrative. It's looking at the supplies as well as the administrative. Now, there are two types of PEs. We have the facility, which is the hospital, and the non-facility, which is the physician's office. It oftentimes is higher in a non-facility, just because we may have less employees, so it may cost us more to run that facility. So it says to see table 8.1 for some setting examples, and that is on page 157. So you can see facility versus non-facility on the bottom of that page. And then the third part is our MP. That's our malpractice. That's our cost of our insurance claims. It also includes any professional liability insurance that we may have. And with this, CMS does collect data from the insurance to help set these. So these RVUs are revised annually, and then every 5 years they look to make sure that the weight is accurate. Our GPCI, remember that this is based on our locality. It reflects that local cost. 90 payment areas, which are known as localities. They can be large metropolitan areas. It can be a portion of the state, an entire state, or it can be rest of state. Those can actually be found on the CMS website. In the textbook, figure 8.1 on page 158 shows you an example of that GPCI. You can see that the GPCI is applied to each of the categories. So we have a GPCI for the work, a GPCI for the PE, as well as a GPCI for the MP. So one GPCI for each of the three RVU categories. And you can see where it is listed there in figure 8.1. So everything is adjusted for that. Next, we have our conversion factor. That's what's going to transfer that RVU into a fee schedule amount. That's set prior to the start of the rate year, and it remains constant throughout the year. This is Medicare's direct control on Medicare payments, and it is updated annually, and it publishes in the Federal Register. CMS can increase that conversion factor, and they do that to either increase or decrease payments, just depending on any of their research that they find. So this is a fancy looking formula here. This is the formula that is used to calculate the payment. So you have your RVUs that have their geographic, and we add them together. All of that multiplied by the CF gives us that fee schedule amount. So the RVUs are converted to the reimbursement amounts. They're published in that fee schedule. That fee schedule is the maximum amount of reimbursement that Medicare will allow for a service. And it is a complete list of payments for services by the HCPCS codes. So your third-party payers that utilize the RVRVs for reimbursement, they modify their system to kind of fit their own needs by modifying the CF. So there's an example. Instead of a CF of 33, a payer may use the CF for 52, and that's just an example. Our provider is going to receive 80% from Medicare. And the reason for that is that a lot of times, remember that there is cost sharing. So there's still going to be a 20% co-insurance. So if my co-insurance is 20%, then my patient is going to need to pay that 20% of that cost share, even if the deductible is met. Could be more if they, the patient may have to pay more if they have a deductible. If you look, table 8.2 on page 159 shows you an example of a full calculation using that formula, where it's showing that the patient has the work value practice expense malpractice multiplied by the GPCI. You add those together, you get 1.68. It's then multiplied by the conversion factor. And then it has the adjusted payment for any adjustments that need to be made. And then figure 8.2 shows you how you get that Medicare beneficiary with that 20% going from the patient and then 80% coming from the Medicare provider. Now, while we're on page 159, let's look at those check your answers. So the first one says for us to define RBRVS. So remember that the RBRVS is that measurement system that gives a value to all of our HCPCS. In the RBRVS, which element is the biggest? Remember that that is work. Number 3, it says list 3 of the 6 practice elements, and you can see that those are listed on the top of 157, but that could be any of those 6: the administrative payroll, clinical payroll, office expenses, medical material and supplies, medical equipment, and then any other. What does GPCI stand for? GPCI stands for our geographic, let me make sure I get it right, Geographic Practice Cost Index. Remember, that's where we compare it to our locality. And then what portion of that fee schedule is paid by Medicare? Remember, that's going to be 80% because we have 20% that is coming from the patient. Now remember, why is that? Because we are looking at HCPCS patient codes that are used primarily in facilities that are outpatient. Remember, HCPCS CPT are primarily outpatient, so we're usually most often going to have an outpatient 20% co-insurance. These, again, remember, are paid for by Medicare Part B, which, as we learned in the beginning, has a 20% co-insurance. All right, let's move on. This is our fee schedule. And we're actually going to do some exercises with this in our homework. We'll look at this a little later, but this is our CMS lookup tool, and it actually is a free tool for offices, facilities to use. Now, there are some things where we get some adjustments because this is payment adjustment for services that may be some special circumstances or some other types of consideration. So, first of all, we have the clinician type. We have participating provider. That's known as a PAR, participating provider. We have a non-participating provider that accepts assignment. That's a non-PAR. And then we have non-participating provider that does not accept assignment. And this a lot of times is called balance billing. So a participating provider means that they participate in Medicare, they have signed a contract, and they agree to the Medicare bill. So whatever Medicare pays, that's what they will take. A non-participating that accepts assignment, non-PAR, they're going to take less than they will take Medicare, but at a 5% deduction. And then the non-participating that does not accept assignment, they don't take Medicare, and they can have anywhere from a 95 to 115%. So it may be 5% less than Medicare, or it may be 15% over. The fee schedule rates are adjusted, and that is on page 161. So you can see those numbers that I just talked about. 161 at the top of the page. So I have a PAR. Remember, they are considered a Medicare participating physician. Reimbursement is $50. So they're going to get their $40 from Medicare, and the beneficiary will pay $10 because of the 20%. Now, a non-participating, they're going to take that 5% deduction. They're going to get $38, which is the 80%, and the beneficiary will pay $950. That's the 20%. That non-PAR, non-accepting, remember, anywhere from 95 to 115. Medicare is not going to reimburse. And you can kind of see how they do the reimbursement there. It's a little bit more confusing there. So MAC reimburses the beneficiary 38%. The beneficiary reimburses the physician $950, and then the beneficiary reimburses the physician $713. So in that case, it's almost like the person that lost out was the physician, not the patient. Next, we have an anesthesiologist. They use a separate and unique payment system. They use base units for anesthesia services, time intervals, conversion factors. Now, if you've done 2400, then you know that they do that formula that you did in class. It's a separate anesthesia formula that they use using base units for anesthesia, time, and conversion. And then our non-physicians, that would be our nurse practitioners, physician's assistants, they work on something called not incident to. So if the fee schedule is when it's not incident to nor under the direct supervision, then those providers get paid 85% of the fee schedule. So let me tell you what incident to means. Incident to are services that a non-physician provides to patients in a doctor's office under a doctor's supervision. So if it's incident to, that means the services are those that a non-physician clinician provides in a doctor's office under a doctor's supervision, and they pay 100% to the doctor, and then the doctor pays the non-physician provider. But if it's not incident, so that means that they may not be in a physician's office or under a doctor's supervision, they're going to get 85%, so they're going to take out 15%. Now, There are also some modifiers that are special circumstances that allow us to modify procedures. We've learned about those also in 2400. Bilateral procedure. So it could be, first of all, the lesser of the actual charge or 150% of the amount. Multiple procedures on the same day. We've talked about that one before. First procedure is paid at 100%. The second through the fifth is 50%. And then if it's 6 or more, it requires review. And then 16% of the fee schedule if you are a physician that assists with a surgery. And there are a few other, but these are the primary modifiers. We have our underserved area adjustment. That's our incentive for the doctors to provide those services. The providers do receive a 10% increase in payment. It's a way to attract those doctors to those areas. And there are addresses for these, and it's decided by the U.S. Health Resources and Service Administration. And that's the health professional shortage areas. Now, in your textbook, page 162, it again shows you that formula of how you get to that final payment. The first thing, though, always remember, the first thing we have to do is we have to adjust each piece of that RVU for the geographic factor. We add those up and we multiply it by the conversion factor. So adjust the RVU for the geographic factor, add each of those up, multiply it by the conversion factor. Now, there are some examples on page 163 and 164 that are listed there. Example 8.1 is showing you how an esophagoscopy is reimbursed. So you can see it's got physician work, practice expense, malpractice. It shows you how those, first of all, RVUs are adjusted for the GPCU. Those results are added up. The result of the total RVU, it's multiplied by the CF of 33.89, total amount of 152.89. So the final payment amount would be that 152.69. Example 2. This is a nurse practitioner. She's at a clinic. She does not work incident to. So if she doesn't work incident to, remember she's only going to get paid 85%. And you can see how it broke it down. Read through those steps. And then the last section is our quality payment program. So this is our QPP. This was mandated by Medicare Access, and it links physician payment to quality measures and cost-saving goals. So high value, high quality. We have the merit-based, the MIPS, and then we have the advanced alternative payments, or the APMs. If they're not meeting the standards, then the incentives aren't going to be in place. There is a list on page 164 of the objectives. The MIPS consolidates the Medicare meaningful use that we used to have. We have PQRS. We've had so many of these incentive programs. And so this is kind of where we've ended up. They receive a bonus based on their performance on metrics for for cost, quality of patient care, improvement to clinical care processes, their engagement with their patients, and then the use of the certified health record. So it's a way to link quality and efficiency. Then we have the advanced APM. This has a risk for the provider and it offers a significant reward. So it's kind of a two-sided. So with this one, reimbursement is a blend of traditional and per beneficiary. You have a blend of fee schedule and capitation. Incentives are given in advance with this. So the facility actually receives payments quarterly. And then if they don't provide the quality feedback, then they may have to pay back their incentives. And a lot of their payments may be based on their E&M services. All right, so we have Olivia. She went out for a run, and 2 blocks from home, she sprained her ankle. Her husband took her to a network urgent care, community urgent care for treatment. He submitted a claim to SuperPayer for the encounter. SuperPayer uses a fee schedule for physician services. It's common for commercial insurance companies to reimburse higher than Medicare and Medicaid. SuperPayer reimbursed Dr. McGee $166.65 for this encounter. Let's compare that to how much Medicare would pay for this urgent care. So you can see that what they did was in your textbook on page 165, they went through and they showed you that if we use the RVUs and apply the CF, the total RVU was 99203. So let's see. In that case, it shows that Medicare would have reimbursed $112.84. Your pricing is a little bit different in your textbook. It says in your textbook that the doctor got $183.15, but even with this amount here, Medicare still paid less. So kind of go through and read how they got to those prices. All right, let's look just a minute at our extra RVRS. Let me get the right one going. Okay, so here we go. All these terms, there's our geographic practice cost index, malpractice, our fee schedule, what it is, RVU, there's our RVRVS, there's services, settings, providers. Again, remember it's under Part B of Medicare. 2 parts. This assigns the value to the HCPCS. This is our fee schedule. We multiply this times the conversion. There's a little bit about each one of those. Remember, 3 categories. Every category gets its own GPCI. There's the 3 pieces of our RVU. Kind of went through all of that. Again, remember that sometimes the third parties do have their own RVRVUs. Here's a couple of examples that we looked at in our textbook. All right, there's that one. Now let's look at the other. Not this one. And this is our systems. This is that HPSA. That's for those doctors that get that incentive because they're in a area with decreased providers. Here's that term incident to and non-incident to. Remember that there's a difference in the amount that they pay. Non-participating and participating. Remember that non-incident to, they get 15% deduction on their payment. Here's how we get some added money, those modifiers. There's that example of that calculation. They're showing you how they got that because it was a nurse practitioner. Here's the PAR and how they get paid. So that is Chapter 8. Now, this total exam has 33 questions. There are 16 questions from Chapter 8. The test does cover Chapter 8 and Chapter 9. It will be 2 separate recorded lectures.